that we have the 47th session of the IMC Family Medicine Club. And this has been started about 4 or 5 years ago. Continuously we're striving to give you the updates in the most challenging part we encounter in our day-to-day practice as a primary care physician and a family physician as well. And we are always trying to bring to you the elite professionals representing different specialties to enrich our insight as a primary care physician and to know from different perspective how these people in those specialties look into us as a primary care physicians once we refer or once we interact with them, to know how we value our contribution to the welfare of our patient and to optimize the resources and to uplift the competencies of our profession in our healthcare system. So today we have 2 important topics today. One is the sympathetic overdrive and its contribution to hypertension, which I really very sure that we deserve to learn more about this because we encounter a lot of cases that represent this modality. And the other one is regarding the prediabetes, which is unfortunately till today is not well tapped by us. We tend to ignore that prediabetes is a disease. It's not a pre-diabetes, it's a disease by itself. And it deserves that we look into it and work on it in order to prevent diabetes. And as we have been privileged nowadays as a primary care physician to be well equipped with the new pharmaceutical agents and even the labs and even the knowledge and the guidelines that promote us to work hard to highlight our competency in preventive medicine rather than curative medicine. So again, we are also privileged to have our colleague, أنا بسميها بنتي عبير الفقيه, who is R3 resident. I've been privileged to be her mentor, looking into her career in the pathway of being a famous, inshallah, family physician. So we will test her today to see how she is going to present her part. So with this wealth of gathering that we have been also privileged to have online attendees with us, and I think this will be a good interaction, to have this kind of dialogue of questions. So without any further ado, I would like to thank Merck for giving us this wonderful opportunity to be here together. And I would like to also to thank all of us scientific society, which is the Family Medicine Society, for having this scientific event under its umbrella. So without any further ado, I would like to introduce my colleague, Professor Muhammad Salah. He has a very huge list of contributions and privilege, but I would like to say that he's very dear to my heart, and I'm sure that we are going to enjoy his presentation. He's a professor of internal medicine, Faculty of Medicine, Cairo University in Egypt, and he's a consultant in internal medicine and the head of the internal medicine department GMP, and now he is in King's College. Yes, all right. So he's going to shed a light on the turn down the overdrive volume. So ladies and gentlemen, we would like to welcome Dr. Muhammad Salah on the stage, and looking forward to hear from you. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ashraf, for this nice introduction. First, I'd like to thank the Saudi Society for Family and Community Medicine, Family Medicine Department of IMC, for giving me the opportunity with you tonight to discuss one of the most important aspects which we face in our clinical practice, which is hypertension, and to highlight some of the missed underlying pathophysiologic contributing factors for hypertension. As per the latest WHO literature, this is a global report on hypertension, and they'd like to nominate hypertension as the silent killer, because we know that non-complicated hypertension is usually asymptomatic. And therefore, when we go for the epidemiologic studies, we'll find that 1 of every 3 adult population is found to be hypertensive. And being a symptomatic disease, that 1 in every 2 hypertensive patients is unaware that he has hypertension. And despite the vast development of the diagnosis and treatment of hypertension, yet the level of control worldwide is less than 20%. That is 4 out of 5 people with hypertension are not adequately controlled, and this is worldwide. And we all know that hypertension is an important risk factor for many target organ damage, particularly the brain, for the stroke, the heart, whether myocardial infarction or heart failure, as well as for the kidney. What about the state here in Saudi Arabia? We are not different from worldwide. According to the latest publications about the epidemiology of hypertension in Saudi populations, which has been published in 2021 and 2022, they found that the prevalence of hypertension in 2019 was almost 30% of adult Saudi population. And again, 1 of every 2 patients with hypertension is not controlled. And the most people with hypertension receive pharmacological treatment thanks for the Saudi government and the obligation of medical health insurance, but still overall rate of hypertension control is still less than 50%. So despite the vast improvement in the healthcare system and the availability of medications through the health insurance for our patients with hypertension, still we are far from the best control for hypertension. And we know that the lifestyle, obesity, diabetes, and dyslipidemia are prevalent risk factors for the development of hypertension. And this is represented also an economic burden. As you see, the economic burden of the cardiovascular disease in Saudi Arabia is expected to increase from $3.5 billion in 2016 to more than $10 billion in the coming 10 years. Therefore, it is going to be tripled in the coming 10 years. And this is a huge economic burden on the economic status of the country. One of the important factors for the pathogenesis of hypertension is the sympathetic nervous system. Despite hypertension is not related to only one factor, it might be related to the salt and water retention, to the activation of the renin, angiotensin, aldosterone system. Again, the sympathetic stimulation is very important. And 30 years ago, if you have the opportunity to attend any international Congress regarding the management of hypertension, at that time, the 2 main lines of treatment as first-line treatment were either a thiazide diuretic or a beta blocker, which were at that time even the non-selective beta blockers. And this is because of the importance of the contribution of sympathetic system stimulation for the pathogenesis of hypertension. We know that the sympathetic neuronal factors are involved in many homeostatic mechanisms and has been contributed and related closely to the development of metabolic syndrome with hypertension and dyslipidemia, as well as insulin resistance. And this is a very important risk factor for the development of cardiovascular disease. And the sympathetic overstimulation can be triggered either by stimulation of the carotid baroreceptors, by the insulin resistance syndrome, or by certain humoral factors like release of renin and angiotensin II. And this complicated slide showed the outline of the underlying effects of sympathetic overstimulation. And if we'll go that, you will find that sympathetic stimulation can have a positive chronotrophic effect on the heart, which will result in increase the heart rate. And this increased heart rate can result in tachycardia, and this tachycardia can even end with tachycardia-associated cardiomyopathy and heart failure. On the other way around, it can result in arterial vasoconstriction, and this will result in increased blood pressure. It can affect the oxygen consumption within the myocardium and resulting in myocardial ischemia. It is a contributing factor for obesity and insulin resistance, and even eventually it can end in either myocardial infarction, heart failure, or even sudden cardiac death. And if we'll go for the effect of sympathetic nervous system on the heart rate and the effect of heart rate on the risk of mortality in young men, we'll find that in this French men study, which has been conducted among individuals less than 55 years of age, and it stated the rate of coronary heart disease, cardiovascular disease or all-cause death compared to heart rates between 60 and 80, we will find that as the heart rate increases, you will find that there will be increased coronary heart disease, cardiovascular disease, or all causes from 80 to 100. And even if the heart rate is more than 100, you will find a statistically significant increase in all-cause mortality, disease related to coronary heart disease or cardiovascular disease. Again, if we'll go for the resting heart rate, we'll find again the elevated resting heart rate will increase the risk of sudden cardiac death 3.8-fold in those with a heart rate more than 75 beats per minute compared to those with heart rate less than 60 beats per minute. And therefore, tachycardia or increase the heart rate, because we know that the definition of tachycardia is a heart rate above 100 by definition, but even if the resting heart rate is above 60 to 80, will have a substantial increased risk for the development of coronary heart disease, cardiovascular disease, and even sudden cardiac death. And therefore, in clinical settings, how can we identify a patient with sympathetic overdrive? This is attributed to patients who have hypertension associated with young age, obesity, metabolic syndrome, diabetes mellitus, or patients with family history of hypertension. And we should look for heart rate, even the resting heart rate, the heart rate variability, and the muscle sympathetic nerve activity, as well as circulating plasma norepinephrine. And therefore, in clinical settings, we will find that young, obese, patients with hypertension, who have diabetes, who have family history of hypertension, who have increased resting heart rate, is a well-known prototype for a patient with sympathetic overdrive. What is one of the most important challenges for the sympathetic overdrive is that when you study the effect of lifestyle modifications on blood pressure, you will find that the sodium restriction, as you see, it has good effect on lowering the blood pressure, whether the low or the marked low sodium intake. But on the other way around, it will result in reflex increase in the muscle sympathetic nervous system stimulation. And therefore, despite it looks appealing to reduce salt intake to get blood pressure controlled, yet it has another effect that it will stimulate the baroreceptors and increase the sympathetic nervous system activity. And therefore, the beta blockers, which is the blocking for the beta adrenergic receptor, has a very important role in the whole journey of hypertension and its complications. You will find that it lies in the center for the risk factors for the hypertension, whether there is hypertension, diabetes, smoking, or dyslipidemia. It will reduce the left ventricular hypertrophy, coronary heart disease, myocardial ischemia, myocardial infarction, and its neurohumoral actions. It will affect the arrhythmias and the loss of cardiac muscles, the cardiac remodeling, as well as ventricular enlargement, and therefore it can prevent eventually congestive heart failure and death. After the introduction of the new molecules for the management of hypertension, we test their effect on the sympathetic nervous system. And the renin-angiotensin-aldosterone system blockers are associated with effect on the sympathetic nervous system through inhibition of renin release. But what we'll find that they affect mainly the peripheral central sympathetic nervous system, whereas only beta blockers have an effect on the peripheral as well as the cardiac sympathetic nervous system. And therefore, they appear to be cardiac specific in abolishing the effect of sympathetic stimulation on the cardiovascular system. And therefore, heart rate reduction seems to be a cardioprotective, as it is an independent risk factor for both cardiovascular morbidity and mortality. And therefore, patients with coronary heart disease who have elevated heart rate, they have lower time for the ventricular coronary diastolic filling and increase the cardiac load, and this will result in more ischemia, angina, and myocardial infarction. And therefore, if you give beta blockers for these patients, you will minimize the risk of cardiac death, all-cause mortality, and the recurrence of non-fatal MI. And they have found that each 10 beats per minute reduction of the resting heart rate will result in 30% reduction in the relative risk of cardiac death post-MI. And that's why beta blockers should be used in all patients with hypertension associated with coronary heart disease. As we all know that the beta receptors have been classified mainly into beta 1 receptors and beta 2 receptors. Beta 1 receptors are mainly located in the myocardium and the kidney, where they will, as I mentioned, beta receptors will stimulate the heart rate and the contractility. They will stimulate myocardial necrosis and apoptosis, and they stimulate insulin release, well as the beta 2 receptors are mainly in the pulmonary and the peripheral circulation, causing pulmonary bronchodilation as well as vasodilation. And therefore, if you'd like to use a beta blocker, you should use a beta blocker with beta 1 selectivity in order to maintain the effect on the beta 2 receptors, which seems to be a beneficial effect. And therefore, beta blockers are particularly beneficial in patients with hypertension, with central obesity, diabetes, or insulin resistance, which are the hallmarks for the sympathetic overdrive. Because this is associated with increased insulin resistance, increased leptin, and increased norepinephrine release. And if you give beta blockers, it will counteract the ventricular arrhythmia. The beta 1 stimulation induce the cardiac and the coronary damage. The effect on the the beta receptors and blood pressure. Therefore, they increase. They abolish the non-dipping effect of hypertension at night. They will act on the kidneys, increasing the intraglomerular pressure and nephropathy. Therefore, they abolishing the release of renin and its conversion of angiotensin to angiotensin to angiotensin 2. And if we'll go for the effect of beta blockers in the obese patients or high-risk patients with type 2 diabetes, in this 20-year follow-up study for the UKPDS, where the original beta blockers at that time, which were not the cardioselective beta blockers, they found that beta blockers compared to the ACE inhibitors at that time was captopril. They found that there was a 23% reduction in death from any cause in patient receiving a beta blocker compared to ACE inhibitors from the UKPDS trial. Again, if we will go for the additional protection, we'll find that the time of introduction of beta blockers in the treatment of hypertension is very important. As you see here, in people with history of coronary heart disease, entry after acute myocardial infarction has more beneficial effect than those with chronic coronary syndrome. Therefore, early introduction of the beta blockers in the course of patients, treatment of patients with hypertension and history of coronary heart disease is much more beneficial than waiting for later introduction. Despite there is a benefit, but this benefit is much less compared to the effect you get when you introduce the beta blockers early. And as you see, this is in comparison to other lines of treatment where you will not find significant reduction compared to these issues. As you see, the hazard ratio is only 16%. This is the classification of the beta blockers. You will see, we know that we have non-selective and we have the selective. We have beta 1 selective. We have the beta blockers with intrinsic sympathomimetic activity and beta blockers who are water soluble or lipid soluble. And as you see for our molecule today, which is bisoprolol, it is a beta 1 selective, high beta 1 selectivity. If we'll go for the recent guidelines for the treatment of hypertension, we'll find that the European Society of Hypertension in 2023 for the management of arterial hypertension stated that beta blockers should be used at initiation therapy or at any step for the guideline-directed medical therapy. Beta blockers can be used in combination with any other drug or in several other conditions. Again, patients who have hypertension and resting heart rate 80 beats per minute or more, or patients with hypertension and the chronic obstructive airway disease are two selected indications for the use of beta blockers from the start. As you saw, this is the guidelines for the treatment. Again, all guidelines nowadays are stressing starting by dual therapy in a fixed dose, fixed bill combination, it's small dose, and up titrate according to there is patient response. And again, they start by an ACE or R plus a calcium channel blocker or a diuretic, whether thiazide or thiazide-like diuretic. And they found that up to 60% of patients can be controlled on this combination. If not, you will go for a triple combination, and therefore, if not, you will go for resistant hypertension. But I'd like to withdraw your attention here that beta blockers can be used as monotherapy at any step of a combination therapy, especially if you have a compelling indications in the presence of sympathetic overdrive or coronary heart disease. This is the national Saudi guidelines for the use of beta blockers in hypertension, and it is stated clearly that beta blockers might be considered as the first line setting for specific indications, such as younger people with hypertension and sympathetic overdrive, or other compelling indications like ischemic heart disease, heart failure, obesity, or patient undergoing bariatric surgery. Again, in the Canada Hypertension 2020, it recommended beta blockers as an initial antihypertensive therapy. Again, they started with the same, but they recommended beta blockers to be used in patients 60 years of age or less. What about bisoprolol? Bisoprolol is a beta-1 selective beta blocker. It is have a high 90% absorption rate for the pharmacodynamics, a bioavailability more than 90%, 30% plasma binding protein. It is 50% metabolized by the liver and 50% excreted by the kidney, and it has an elimination half-life of 10 to 12 hours. And it has, as I mentioned, 50% renal elimination of the unchanged drug and 50% hepatic metabolism to inactive metabolites. And metabolism is only by oxidation. It doesn't interact with cytochrome B2D6, but it is primarily interact with the cytochrome B3A4. And there is no dose adjustment necessary in mild to moderate liver or kidney impairment. And for the management of hypertension, the daily dose is maximally related to 10 milligram in patient, particularly patient with severe liver or kidney disease. Again, this is a comparison between the different beta blockers, comparing between the increased beta-1 selectivity and the increasing beta-2 selectivity. I found that bisoprolol has the highest beta-1 selectivity compared to others like atenolol, metoprolol, or betaxolol. And we know that propranolol is a non-selective beta blocker. Again, if we will go for the beta-2 to beta-1 selectivity ratio at human beta receptors in vitro, we'll find again bisoprolol has a 20-fold higher affinity for beta-1 receptors than for beta-2 compared to the metoprolol, atenolol, and carvedilol. Again, if we'll go for the effect on the 24-hour blood pressure control with bisoprolol versus atenolol after once daily therapy, we'll find that the effect of bisoprolol has been maintained over the last 4 hours before the next dose compared to atenolol, whether the systolic or the diastolic blood pressure. Again, if we'll compare bisoprolol with other lines of treatment, including the ACE inhibitors, calcium channel blockers, or hydrochlorothiazide, again, we will find that bisoprolol has a statistically significant more reduction of blood pressure compared to losartan, amlodipine, and hydrochlorothiazide, whether this is systolic or the diastolic, and both are statistically highly significant. Again, if we will go for the 24-hour ambulatory blood pressure responses, again, we will find bisoprolol has maintained the ambulatory blood pressure reduction statistically significant lower than losartan, amlodipine, and hydrochlorothiazide. Again, it has been found to be superior to the antihypertensive therapies, not only in the context of blood pressure lowering, but also in the context of heart rate reduction compared to amlodipine, doxazocine, lisinopril, and bendrofluoride. Again, it was found to be superior to losartan in middle-aged hypertensive patients regarding the systolic blood pressure, the diastolic blood pressure, as well as creatinine clearance, when bisoprolol is a dose of 5 milligram compared to losartan at a dose of 50 milligram per day. Again, compared to nebivolol, this was a non-inferiority study conducted by nebivolol in comparison to bisoprolol. It has been found nebivolol is non-inferior to bisoprolol regarding the blood pressure reduction, whether the systolic or the diastolic, or even the response rate. Again, this is the control of raised blood pressure in compared to atenolol in smokers. You will find that, again, patients who are smokers, the bisoprolol resulted in more reduction of the blood pressure compared to atenolol, whether bisoprolol 10 to 20 compared to atenolol 50 to 100 milligram, whether in non-smokers or in smokers. And as you see, even in smokers where the sympathetic overdrive is much more, you find much more reduction with bisoprolol compared to atenolol. Again, what is the mechanism of this beta blocking in cigarette smoking? We found that the bisoprolol is compared to those who didn't take beta blockers compared to placebo, whereas metoprolol and the non-selective beta blockers, the effect on the sympathetic overdrive in smokers was not as much as compared to bisoprolol in a dose of 2.5 to 10 milligram for cigarette smokers. And by this I end. Thank you.
Thank you so much, Professor Muhammad Salah, for this wonderful presentation, which was really insightful. And this generates a lot of questions that touch our concern from our primary care practice point of view. And now I would like to introduce our second guest speaker, Dr. Nibras Al-Sayegh. He has the American Board of the Internal Medicine, American Board of Internal Medicine in Endocrinology and Diabetes and Metabolism and Oncology Endocrinology trained certified Medical University of South Carolina. Currently, he is a consultant in endocrinology and the head of the endocrinology department in the International Medical Center. So now he's going to shed a light on navigating the pre-diabetes management. I think this is our core business as a primary care physician, to focus on pre-diabetes and to prevent diabetes. So we are here to hear from Dr. Nibras, and I would like to welcome you and thank you for accepting our invitation to be part of this scientific event. ممكن مايك لأنه هذا
طيب السلام عليكم everyone. أول شيء شكرا دكتور أشرف على very nice introduction, and thank you for arranging this scientific event. Thank you everyone for attending. It was a long way for me and I lost, so alhamdulillah I arrived on time. So let's start our talk by showing that there is an opportunity for prevention for the pre-diabetes. This is outline of my talk. So the importance of early treatment for pre-diabetes and diabetes prevention data, what is the DPP and DPOS, the diabetes prevention program and the outcome study, and diabetes prevention data of Chinese program and management of pre-diabetes per recent guidelines. This is the prevalence of diabetes in Saudi Arabia. في ليزر هنا ولا ما في ليزر؟ ده؟ كده okay, it's fine. It's fine, someone else. This is the prevalence of diabetes in Saudi Arabia. As you can see here now, I mean, this is from the IDF, the International Diabetes Federation. We have 23% prevalence of type 2 diabetes in adults. This is age standardized prevalence. And almost 27% of pre-diabetic, which is prone to develop diabetes in the next 5 to 10 years. This is scary for me. It's a huge number. So 2 out of 10 diabetic, same number, I mean, another 2 or 3 patients are pre-diabetic and they are not aware. So this eventually will develop diabetes because of this asymptomatic and they are not aware of their condition. So pre-diabetes is a term for a patient who has high blood sugar but not quite reached the diabetic range, but it's not quite normal as well. So it's defined by 2, either impaired glucose fasting, which is blood sugar above 100 but below 126, or impaired glucose tolerance. And for the A1C, we cannot label them. This is a screening, but as definition, these are to diagnose pre-diabetic patients. And of course, there are increased risk to develop diabetes. As we all know here, for the fasting blood sugar, 100 to 126, this is the range of pre-diabetes. For glucose tolerance or random blood sugar from 140 to 200. For A1C, 5.7 till 6.5. So pre-diabetes is asymptomatic and no sign, no symptoms. 90% of the patients, they are not aware of being pre-diabetes. But there is a risk factor, and there is an individual at high risk of being pre-diabetic. We all know the overweight or obesity, family history of diabetes, gestation diabetes, high blood pressure, and dyslipidemia. This group at higher risk of becoming pre-diabetes. And as you mentioned, it's almost two type or two form of pre-diabetes. First, impaired fasting glucose, when the hepatic insulin sensitivity or resistance starts, and for the muscle insulin sensitivities remain stable. So patients have high fasting blood sugar, but normal postprandial. For the impaired glucose tolerance, then we have normal hepatic or near normal hepatic sensitivity of insulin, but the muscle insulin resistance increased significantly with high blood sugar after meals while fasting is normal. So as we all know, type 2 diabetes is a cardiorenal metabolic continuum. So it's a cascade of events. Start here with prediabetes. Patients with prediabetes, they're already at cardiovascular risk. They already have this glycemia. They are obese or overweight. And most of the complications, not most, macro complication and some of the micro complication are cooking underneath here. Insulin resistance, some renal hyperperforation, and increased cardiac risk. So when the patient is labeled as diabetic, then we're already at high risk of complication. And we mentioned 25% of the patient, they already have established micro and or macro complication. I'm not going to go in the advanced diabetes because all the cascade now, at the end, all the communication has been developed. So we want to act here early and to prevent all this communication. This cardiometabolic continuum. Of course, we start with risk factors, like we mentioned, obesity, hypertension, dyslipidemia, dysglycemia, secondary lifestyle, and smoking. So when we see this patient with high risk, we need to prevent the continuum. They start with subclinical atherosclerosis, then they develop diabetes, and the cascade goes on. So all the message here is to act early to prevent. So what's the risk for the patient with prediabetes to develop diabetes for the next 5 years of diagnosis? If we take different A1C level, so from 5.5 to 6, 25% or 10 to 25% will develop diabetes in the next 5 years, and this number is triple. So when we cross the 6, that's why 6% of hemoglobin A1C is a landmark of severe or very high risk to develop diabetes, because the risk now is triple. Almost 60% of patients with prediabetes who has A1C more than 6 will develop diabetes in the next 5 years. What about if you compare it to the normal? So here we compare the risk of developing diabetes with A1C less than 5. So 5 to 5.5, you have twofold risk increase of developing diabetes compared to normal individual. From 5.5 to 6, then it is five time or five-fold increase. And when you cross 6, it's quadruple. And that study is triple, now quadruple. So it is the 6 is the landmark here to make us kind of take it very serious with our patient. We need to act. We need to reduce that to prevent all this, or to prevent them to become diabetic and to prevent all the complication came with diabetes. So they are at high risk. 10% or 11% per year of pre-diabetic patient will develop diabetes, and lifetime risk is 70%. So 2/3 of the pre-diabetic patient will become diabetes in the lifetime. And they are high risk for diabetes, not only diabetes. They are at high risk for all the complications, all the micro and macrovascular complications that occur with diabetes. The pre-diabetic patient, they already have higher risk compared to normal individual. So not as high as the diabetic patient, but it is significantly high compared to a normal individual. We have peripheral vascular disease, retinopathy, nephropathy, all the micro and macrovascular complication, as you mentioned. Why is that? Because I think we all know this. This is the start. This is the landmark of starting of prediabetes. So the first pathogenesis of prediabetes or of dysglycemia is increased insulin resistance and increased insulin secretion. Go with it. So this is the time, even the fasting blood glucose and impaired glucose tolerance is still normal, but this is the time that most of the complications start to develop. So we want to act here, even with normal thing. So that's why sometimes A1C is misleading us, that we have many patients with normal A1C, but fasting blood sugar is high. Or like in my practice, I don't really screen with glucose tolerance test. But I think we have to, especially if patient with the high risk of prediabetes, because we miss this window. So a patient may remain in prediabetes for years, 5, 10 years, sometimes lifetime, but there is complication is developing underneath. So early diagnosis and early intervention is the key here to prevent all the complication of becoming diabetes. Now we're going to focus on the DDB and DDBS, the USA study. It is diabetes prevention program and diabetes prevention program outcome study, the extended for 15 or more than 15 years. This is a different diabetes prevention program developed. So in average, they show reduction of incidence of diabetes by 50 to 60% compared with without doing any intervention. So here's the structure of the study. So the first 4 years of the study, they divide patients in 3 groups, all of them at high risk of becoming diabetes, pre-diabetic, or impaired fasting blood glucose, or A1C more than 5.5. So this is lifestyle intervention, intensive. This is metformin alone. This is placebo. After 5 years, they found a significant reduction in incidence of diabetes with lifestyle intervention. So they make change here. They put everyone on lifestyle intervention. So intensive group, and they call it modified lifestyle intervention, which is most cost effective and less aggressive. And we talk about the detail about aggressive. Here it was, one-to-one classes, frequent monitoring, and observed, and with the structure program, and with the aggressive weight loss goal, more than 7%. When they modified, they make this less, the goal is less kind of strict. So A1C was, weight loss was less than 7 or 5% is okay, and was not self-monitored and just kind of group exercise or something like that. So then what they found, this is the structure of the study. The study design, 3,000 patients, BMI 34, blood glucose level is higher than normal, and average study duration was almost 3 years. Lifestyle intervention, and this is was aggressive, metformin, BID, 850, placebo, and testosterone, but was stopped after I think 1 year. So what they found, this is the first 4 years of the study. There is 31% reduction of incidence of diabetes, patient of the group taking metformin versus placebo, while lifestyle was the winner here. It was almost 58% reduction. So a significant difference between lifestyle and metformin, but all of them was significant difference between both of them and placebo. So intervention make a big difference in these patients. And then they follow up after 10 years, and the metformin group sustained reduction, another 18%, while for lifestyle after 10 years it was reduced from 58 to 34% in the reduction of incidence of diabetes. So there is major drop between the first aggressive 4 years and the other, but still there is a sustained benefit of both for lifestyle and metformin. Still lifestyle is the winner here, but metformin is closing the gap. It was 30 and 58, now almost 20 and 30, so closing the gap. And after 15 years, even the gap get closer. Because as we all know, to keep intensive lifestyle intervention is kind of hard. Like you start the study at age of 40 and you end up at age of 60. So definitely lifestyle is different when you are 40 than 50. So it's hard to maintain. But still lifestyle was the best intervention to prevent diabetes. This is for the weight loss, because the first 4 years was intensive lifestyle. That's why the significant weight loss. And then after they modify the lifestyle intervention to make it less aggressive, then they must regain their weight, but still they kept a reduction of weight more than placebo. So both group, metformin and lifestyle intervention, kept almost 2 to 4 kilogram weight loss, even after 10 years of the study, compared to placebo. So over 10 years, from a payer perspective, metformin was marginally cost-saving. Of course, lifestyle intervention was cost-effective, but metformin was cost-saving because the program was less aggressive with the exercise and meal, and because including meals, 30% less, fat content, 20% carbohydrate, and 150 minutes of exercise a week, and so on. So when they modify it, it become cost-effective, but metformin group is even cost-saving. This is the 15 years, as you mentioned, so the gap gets closer between lifestyle intervention. The gap is big, 10 years, 15 years. The message is here that both of them are effective. It's hard to maintain lifestyle. It's easy to maintain metformin. Both show sustained benefit. So we need to do both better. Lifestyle is good. Metformin has its advantage. So by 15 years, metformin sustained its lower reduction by 18%, while lifestyle intervention dropped from 58 till 27. Still, it's better than metformin, but it keeps dropping. Because as you mentioned, you start with the age of like 50, you end up age of 70. Definitely your activity, your diet, your energy is different. This is the weight change after intensive lifestyle change. So after the first 5 years with the intensive lifestyle intervention, they exclude that from weight loss. After that, the patient here regained their weight, metformin dropped their weight. So if we exclude the first 5 years of aggressive lifestyle intervention, metformin was the winner. Has more weight loss than lifestyle intervention without metformin. What about for the complication, the microvascular complication? There is 20% lower prevalence of complication for the patient who do not develop diabetes in the study compared to patient who become diabetic. This is a significant reduction, so that's why we need to treat early to prevent the complication, not only diabetes, and also its complication as well. As you mentioned, lifestyle intervention is not suitable for everyone. It's hard to maintain. It was very aggressive. In the other study, the Finland diabetes prevention study, they found not everyone was able to maintain this goal. This is the goal for lifestyle intervention, like more than 5% weight loss. Only 4% was able to achieve that. What about for fat intake less than 30%? Only 47 achieve that. So it's hard to achieve. But when you achieve it, you get a significant benefit. And as you mentioned, with time, you get less motivated, less active, you get lazy with the diet, and so on. So both is good, but you mentioned that if there's a medication that help you to maintain once daily or twice daily, it's very effective in preventing the diabetes and its complication. This was the goal for lifestyle intervention, the aggressive one. As you mentioned, at least 7% weight loss and at least 150 minutes of physical activity a week, which was moderate intensity, not only kind of walking or bicycling or treadmill. Low calorie, low fat, increased fiber. It was class 1-to-1. That's why we achieve a significant here. If you do this, then the patient will get the most benefit. if he's able to maintain this. And it shows that even for 15 years of modified one, we achieve significant reduction. So here the challenge for lifestyle, of course, difficult to maintain, poor compliance, and regain the lost weight over time. And with the patient, if they're unable to keep this, then pharmacotherapy, metformin come at the first line with the proven evidence and benefit of as much as 31% reduction of prevalence of diabetes. This is a different study. The metformin, this is the USA, this is the 10 years or 15 years follow-up. This is a different study. Had different variation because different structure, different study design. But we focus on these three for our talk here. So this is the China Diabetes Prevention Program, which is almost similar to US one, but it's only 2 years, and it's two group, lifestyle intervention, plus metformin or without metformin, and both groups show sustained or decreased incidence of diabetes, 25% and 21%. Different was 17% for the patient who's taking lifestyle plus metformin, of course, because here is the same lifestyle, but we add metformin, we get the benefit of 17% more reduction. And if you separate by different group, subgroup, there's some group will benefit more from the metformin than other. Here they found the age, younger, and patient with high BMI, more than 25, patient with hypertension, and patient with hypertension and overweight. For weight loss, there is almost 1 kilogram difference in 2 years between the two groups, patient taking metformin and also lifestyle intervention, and BMI difference was 0.3 kilogram per meter square. And here with the management for diabetes, of course, we all know, as you mentioned, lifestyle intervention. Most of the guidelines mention that lifestyle modification is the first line therapy, but then metformin come as a first line in many recommendation. If you take EDA, and they have some category that consider metformin for these patients, A1C more than 6, BMI more than 35, age less than 60, or pre-GDM. And for Saudi National Diabetes Center, they almost have the same recommendation, but they decrease A1C from 6 to 5.7. So any A1C more than 5.6 with other parameter consider giving them metformin to prevent diabetes, and it was cost effective and decrease complication. So these are patients at higher risk. So in this patient, I advise you have to start medication. So A1C more than 6, as you mentioned, the risk of diabetes increased by triple compared to normal, on some study 20 times. If you have combined impaired glucose fasting and impaired glucose tolerance, if you have the fasting is high, those who failed the intervention, lifestyle intervention, patient with obesity and IGT, and young, we recommend to be more aggressive in this subgroup because they are at higher risk of becoming diabetes. This is the prevention or screening recommendation for ADA. I think it didn't change for many years now. It's the same for the last 7 years. So we start patient with high risk, BMI more than 25, and or have one of the following risk factors: first degree relative diabetes, high risk ethnicity, history of cardiovascular disease, hypertension, dyslipidemia, as you mentioned before, physical inactivity, and people with prediabetes should be tested yearly. People who have diagnosed with GDM every 1 to 3 years, and for all other people, start with age 35. 1, normal, then consider every 3 to 5 years. Abnormal, following in this fall in this category, then you have to do it yearly. So what's the pharmacological, the option we have? We have metformin. So in the study, they use metformin fast release metformin, and here we have extended release metformin. So if we consider the immediate release with extended release, they have the same efficacy, same bioavailability, same A1C reduction. So we can use it as a study developed because it has better tolerability, less side effect. As we see, diarrhea and any GI side effect has a significant difference between patient taking metformin, standard metformin and metformin XR, more than 50 or 7% reduction in GI side effect. And for adherence, it's once daily, 2 tablets or 1 tablet, but it's only once daily taken. So improve adherence and 30% more adherence improve, and even this will improve A1C reduction. In summary, prediabetes is cardiometabolic risk state. Not only prediabetes phase require early intervention. Lifestyle modification is the cornerstone of the prediabetes management. Metformin is the only widely recommended pharmacotherapy. Individualized treatment is the key. Combine both. One of these depend on your patient. Regular monitoring and follow-up are the essential to prevent developing of diabetes. So prediabetes is the tip of iceberg. I think this has become, I don't agree with this quietly, because meaning that we have complication, not yet. If we diagnose prediabetes, then all this complication is not there. So you can prevent it. So أول لغاية قطرة فهو القطرة فقط. ممكن we can prevent the complication by raising our umbrella with metformin and lifestyle intervention, and we don't have this. It's not established already. Thank you, and open the panel for questions.
Thank you so much, Dr. Nebras, for that. For the iceberg, I believe that the tip of the iceberg is diabetes, and underneath is prediabetes, because prediabetes takes up almost 6 to 7 years before the onset of diabetes, and then suddenly we'll get the tip of the iceberg, which is diabetes, with all complication. So thank you so much for highlighting the prediabetes, the prevalence, the association with the micro and macrovascular complication, and the role of metformin in the management of prediabetes. So now we are going to move and shift the gear to something related to the update in the guidelines of diabetes. Here we have Dr. Abir Al-Faqih. She's a family medicine resident, and this is for the first time, or maybe the second time, we're enrolling our residents in IMC to come and present and to sharpen their skills to communicate and to disseminate informations and to learn how to stay on the stage and be bold enough to give knowledge and informations. So she's a R3 International Medical Center in Jeddah. She has a very good interest, in fact, in preventive medicine, chronic disease management, and quality improvement. So she's going to talk about diabetes and update guidelines. So thank you, Dr. Abir.
Thank you, Dr. Ashraf, to the introduction. And thank you all for the kind attendance. I'm talking today about the American Diabetes Association 2026 guideline, a snapshot. I will highlight some important points in the new guideline. Section 3 regard the prevention of or delay of diabetes and associated comorbidities. Recommendation 3.12, statin therapy may increase the risk of diabetes type 2 in people with high risk for diabetes type 2, even though isn't recommend that to avoid or discontinue statin for this adverse effect. Recommendation 3.30, in people with history of stroke and evidence of insulin resistance or pre-diabetes, bioglitazone may be considered to lower the risk for the stroke or MI. Lower doses may mitigate the risk of adverse effect. In section 4, regard comprehensive medical evaluation and assessment of comorbidities, we should consider in laboratory evaluation, liver enzyme test, and also to calculate FIB4 index to assess the risk of MASH or muzzle, metabolic associated steatotic liver disease and metabolic associated steatohepatitis screening. Screen the adult with type 2 or prediabetes, particularly those with obesity or other cardiac metabolic disorder or already who established cardiovascular disease, for the risk of having or developing cirrhosis related to MASH using calculated FIB4, even if they have normal liver enzyme. Recommendation 4.23, adult with diabetes type 2 or pre-DM with FIB4 more than 1.3 or equal or more than 1.3 should have additional risk assessment or stratification with liver stiffness measurement like fibroscan. Recommendation 4.24, refer the patient with higher risk for developing fibrosis liver cirrhosis disease to gastroenterologist or hepatologist. In this figure, we will conclude the previous recommendation. As we see, the group of patients with higher risk for future cirrhosis, if the FIB4 index equal or more 1.3, if it no, we remeasure the FIB4 index in the annual next visit. If it yes, and it was very high, like 2.67, we immediately refer the patient to the specialist or liver specialist. If it yes, and the fibroscan result showed a liver stiffness measurement equal or more than 8 kilopascal. If it yes, we refer the patient, pardon. Sorry. I'm sorry. Can we open the presentation again? If it yes, we immediately refer the patient to the hepatologist. And if it no, the patient will be managed by the primary team care, and it will be annually calculated the FIB4 risk. This is the FIB4 index. We need the age, AST and ALT, and platelet count. Regarding the management for MASH and muzzled, recommendation 4.26, in adult with diabetes type 2 with muzzled and overweight or obese, consider using GLP-1 or GIP with GLP-1 receptor agonist for the treatment of the obesity with the potential benefit effect in the MASH. Recommendation 4.27a, in adult with diabetes 2 and biopsy proving MASH or those with high risk for liver cirrhosis, bioglitazone, GLP-1 or dual, both GIP and GLP-1 is preferred to glycemic management because of the potential beneficial effect on MASH. Recommendation 4.27b, combination of both therapy of bioglitazone plus GLP-1 receptor agonist can be considered for treatment of hyperglycemia in adults with diabetes type 2. Another figure to conclude the previous recommendation, in muzzled with F0 or F1, if the target or the goal to control the obesity, we would prefer to use GLP-1 receptor agonist or dual GLP-1 receptor agonist with GIP. If it's the diabetes control or hypoglycemia control, prefer to use GLP-1 or dual GLP-1 with GIP or bioglitazone. Section 10 about the cardiovascular disease and risk assessment, risk management, screening for patients with diabetes. Recommendation 10.38a, adult with diabetes at having higher risk to develop symptomatic or asymptomatic cardiac structure or functional abnormality, either stage 1, stage B heart failure or stage C heart failure. Consider screening for all adults with DM by measuring the BNP or N-terminal pro-BNP or other biomedical or biochemical test. Recommendation 10.38b, in asymptomatic individual with DM and abnormal BNP, we should consider echocardiography to either diagnose or prevent stage C heart failure. In this figure, for screening for undiagnosed cardiovascular disease in diabetes patient, to conclude the previous recommendation, screen all the adults, as we say, to risk of heart failure, either if they asymptomatic. If it's abnormal or high, we should consider echocardiogram. As we know, diabetes is heart failure and an underappreciated complication for diabetes, as a consensus of report published from the ADA Diabetes Care in July 2022. Another figure to see stage A and stage B. Stage A with patient with risk of heart failure, or stage B with patient with already have a structural disorder in the heart. We should do the biomarker and assess pro-BNP, BNP, or high sensitive cardiac troponin. If it's normal, if it's elevated, we should consider another we should consider intervention like echo. If it's normal, repeat the test at least during 1 year. Thank you.
Okay, thank you so much, Dr. Abir. And now it's the time to have our panel discussion. So I would like to invite Dr. Muhammad Salah, Dr. Nibraz, and Dr. Abir as well. Dari. So I would like to open the floor now for questions. So if anyone of the audience here have question, Dr. Abdul Hamid, mic please here. Mic.
Thank you, Dr. Ashraf. Thank you for the speakers. We are talking about pre-diabetes, Dr. Nibras. Just a few weeks ago, they were talking about pre-diabetes. A1C 5.4 with insulin resistance, it is pre-diabetes. And it should be managed before the pre-diabetes and before diabetes. So this to stress your talk. Thank you very much. For heart failure, since 2022, the American Diabetes Association position a statement: all patients with diabetes with any risk factor should be screened at least annually for heart failure. So it is very important to look for this. For fatty liver, it is not by ultrasound. It is FIB4 followed by FibroScan. Thank you.
Thank you so much.
You see, Dr. Abdul Hamid, I think our role as physicians is becoming more and more difficult. And your role as physicians in primary care settings is more and more difficult. Now, it's difficult to define the normal human being because we don't know the data. As we dig in the medicine, we find that complications do happen because we know that death is eventual, whatever the life path is. And defining what is normal, even for the hypertension. You remember the guidelines for hypertension and definition of hypertension has been changing over the past 20 years. Yes. What is normal, what is pre-normal, what is low normal, high normal, you see? And that's why I think lifestyle modifications should be adopted throughout the community, from birth till death. I think this is our role mainly as preventive medicine, is to focus on improving lifestyle and trying to get the numbers as low as we can in order to try to minimize the risk and associations of complications.
Absolutely. Well said. Thank you so much. Questions here? أحد عنده سؤال? Yes, here. Mike, please. Because we have a couple of questions from our online
very
audience.
Excellent lecture and excellent program attended by people. I have one question regarding diabetes. There is some change in this level, and because some scientists send me some information that ADA has found this up to 7 is normal. So it looks like just rumor, but please highlight this.
You talk about the diagnosis of diabetes?
Yes.
For now, for the A1C and for the fasting and postprandial, it's the same for now. There's no change in the. For the pre-diabetes is different, so each one defined as different for insulin resistance. But for no hemoglobin A1C is still 6.5 is diabetes. You mean 7% is normal? Our target, like for certain individual, like with high risk for mortality with comorbidity, then we accept a 7 as normal for them. But if you can do something, we do it. Like if you can give medication without any side effect, then we can lower it. But if you have many medication, polymedicine, then we can accept it between 7 to 8. But it's not normal. It's a target for some patients.
Before we have been put, like in frail patients, we put up to 7.5. Yeah, we have to maintain at this level. But what he's sent me some, clip. It looks like some new research has come and some new studies has come. That's why.
Still, all the guidelines have the same recommendation. So I have no comment on what you saw in the clip. So I'm not sure.
Okay, thank you.
Yeah, sure.
Okay. Any other questions? So, تفضل دكتور. Another question here.
Assalamu alaikum. My question to Dr. Nebras. What about the dose and its modification of metformin during pregnancy? And I can reach the maximum dose all over the 3 trimesters. And also, what is the optimal time of taking metformin during Ramadan?
Okay, so for pregnancy, so if we are, I mentioned, if you follow the North American guidelines, the second line, it's safe for pregnancy. It can be given from the first trimester. It's safe, but it's not first line. If we're following some European recommendation, then it is as with insulin is the first line. So it is safe. It can be given from first trimester. Maximum dose 2,000 as usual. We not exceed 2,000. And it can be given once, twice daily, no problem. With Ramadan, if we're using XR, of course we're using with the biggest meal, so with the iftar, after iftar. And if we use the standard or immediate release, then it's twice daily with the big 2 meal. So once daily with the biggest meal, there's not much different, to be honest. Once daily, it's once daily. With how it doesn't make sense. It doesn't make difference. And twice daily, for Ramadan, we didn't adjust the dose for this medication. Some can need adjustment, but for metformin, no need for adjust. Same dose and without risk of hypoglycemia, basically.
Okay, I think I have a couple of questions from the audience. One question for you, Dr. Muhammad Salah, regarding the sympathetic overdrive. It said, at what stage of hypertension does sympathetic overactivity become most relevant? Is it in the early stage, or in established disease, or in the resistance stage of the disease?
It is all through the pathway of hypertension. If sympathetic overdrive is present in all patients with hypertension, but the degree of sympathetic overdrive varies from one individual to another, depending upon some phenotypes, like the younger age, if the hypertension develops at a young age, if hypertension is associated with obesity, with metabolic syndrome, hypertension in ladies more than in men, sympathetic overdrive is there. And you can detect it clinically by the resting heart rate.
Yeah.
If the individual with hypertension has a high resting heart rate, and by high I mean above 80, this will indicate an underlying sympathetic overdrive.
Okay.
And as I mentioned, some of the medications used for the treatment of hypertension have an effect on the sympathetic nervous system, like the ACE inhibitors and ARBs,
Yeah.
through the effect on renin. But still, the effect is mainly on the peripheral sympathetic nervous system, not on the cardiac nervous system. And
Yeah.
that's why most of the guidelines recommend in these patients to treat increased heart rate as an isolated risk factor for cardiovascular disease, and try to reduce the heart rate to between 60 and 70 in the patient with hypertension.
So is it in primary care, is it enough clues to identify the sympathetic overdrive by all these features, the heart rate and...
And the smoking, yes.
Okay.
Yes. It should at least raise your attention to focus on the association of sympathetic overdrive in this patient.
Excellent. Dr. Nebras, the question is how reliable is the A1C across different ethnic groups, especially with anemia and chronic kidney disease, when it's come to patient with pre-diabetes and diabetes?
Yeah, so for different ethnic group, I think it's reliable and it's accurate. But for patient with chronic disease like anemia, hemolysis, recent transfusion, it will be less accurate. It give you false, false negative or less. A1C will be better than it's actually, because we know A1C is connected to the red blood cells. Or if it's die early or hemolyzed, then we lost the accuracy.
Okay.
So either be over or underestimated.
So at what stage in primary care we should treat pre-diabetes? Is it according to the ADA when the A1C is 6, or according to the Saudi guideline when the A1C is 5.7?
Well, it's individualized, but for lifestyle intervention, of course, for everyone, as Dr. said. So 5.5, more than 105, everyone should pay attention to their food, to their lifestyle, to the exercise. But for medication-wise, I usually myself wait until 6. But I think we need to change this practice, because I depend only on A1C. And as you mentioned, impaired fasting glucose or impaired glucose tolerance can be abnormal with normal A1C.
Absolutely.
So we need to take it individualized. Obese, it's high risk.
Yeah.
It's hypertension, dyslipidemia, then we treat this patient. So we take it individualized, at higher risk, treat early, young with A1C less than 6, I usually give them a chance.
Well, I think there is a debate on this.
Yes.
I really treat pre-diabetes in early stage, knowing that pre-diabetes is associated with the microvascular and macrovascular complications. There is a patient who came to me with a peripheral neuropathy, even with 5.6, 5.7. Okay, so, and there is an compelling evidence that is associated with even cardiomortality at early stage, and even chronic kidney disease with pre-diabetes. So that's why we have to be very aggressive. That's why we have to agree on this. Okay, thank you. Dr. Salah, I think there is a question here. How should you think about the beta blockers today in uncomplicated hypertension versus in sympathetic driven phenotype? Yani البيتا blocker, how you look into it now in uncomplicated hypertension?
I usually stress, Dr. Ashraf, that the best guidelines for the treatment of hypertension are those published by the European Society of Hypertension in 2008. When they individualize individuals with hypertension to those with compelling indications and those without compelling indications. Whenever you see an individual with high blood pressure, you should think of this individual as an autonomy, the whole, not isolation. And for this individual, you should stratify what you think is the primary pathophysiology for his hypertension. Whether this is related to sympathetic overdrive, to volume overload, to increased renin activity, or others, because we know that the pathophysiology of hypertension is complex and it varies from one individual to another. And I cannot say that there is one drug for all individuals with hypertension.
Yes.
Again, individualization, proper history taking, proper clinical examination, the detection of the presence or absence of hypertension-mediated target organ damage, and at that time you decide what is the suitable line for treatment for this particular patient. Beta blockers have a role in individuals with hypertension when there is an indication clinically or by ECG or by laboratory that there is an sympathetic overdrive. Don't overlook it, because the problem is that most of the guidelines nowadays are stressing of the use of renin-angiotensin receptor blockers or thiazide diuretics or calcium channel blockers for the initial treatment of hypertension, overlooking the importance of beta blockers, which
That's
can
right.
be added to these lines or be used alone in patients with hypertension. Therefore, there is no one drug which will suit all patients. You individualize according to the clinical scenario you are facing. Paying more attention to history and clinical examination, you will elect the people who can get benefit from beta blockers, renin-angiotensin blockers, or a diuretic.
Excellent. Well said, Dr. Mohammed. Dr. Nebras, at what level we should bring the A1C down in pre-diabetes management with metformin? Is it to the normal 5.6 or lesser?
Yeah, less than. So
Okay.
if we treat, then we need to be aggressive.
Yes.
Yeah. Of course, lifestyle, as you mentioned in the study, lifestyle is the most effective and most sustained and most preferred way, because it's cost effective and it prevents not only prediabetes. It has weight management, improve dyslipidemia, improve hypertension. So I usually emphasize lifestyle. Lifestyle, even patient with medication, without medication, lifestyle is the most important cornerstone.
Okay.
Then, of course, when we treat, we need to bring it below 5.6 to normal reference range. And as you mentioned, not only A1C our target, we can do fasting blood sugar, like sometimes fasting is high and A1C is normal, and sometimes random is high and fasting is normal. So we need to, patient with higher risk should be below 5.5, and again, lifestyle.
Yes, thank you. A real case scenario, a patient who is obese with prediabetes, would you like to treat obesity first or prediabetes?
GLP. Is GLP the answer.
Okay.
So
All
yes,
right.
of course, obesity. I mean, obesity is high risk.
Okay, treat the
So-
insulin resistant first or the prediabetes.
Right.
So which one is which?
Insulin resistant, because this is the cause of prediabetes.
yeah.
I mean, the cause is obvious for us. It's obesity. So
Yeah.
if we treat obesity, then we'll reverse and
Okay.
to normal glycemia.
Absolutely. 5 to 10 and 10 to 15% of the weight reductions is a disease-modifying intervention. And this is what will undo diabetes and prediabetes as well. Dr. Abir, the last question for you. From your own clinical expertise, how do you look into these two clinical entities, prediabetes and sympathetic overdrive with hypertension? What is your experience in this and the challenge you encounter as a resident?
Actually, as you said, doctor, when we see patient with obesity and pre-DM, I noticed if we focus in the weight reduction and obesity target, the pre-DM, even the hypertension, the risk factor will reduce, and we will see only if we focus in the obesity reduction or the weight reduction, both of them will finish with the good outcomes.
Excellent. Thank you so much. So my last question for all of you, one single statement as an advice and recommendation to primary care physicians, sympathetic overdrive hypertension, prediabetes. So what you would like to recommend to enhance the quality of care in these clinical entities as an advice from you.
And I think the whole theme tonight,
Mike.
Ashraf, is that proper screening in the individual settings, whether for the hypertension with sympathetic overdrive, the target organ-mediated complications of diabetes or pre-diabetes, is to identify people who are at high risk of these diseases, screen them well, and manage appropriately.
Excellent. Thank you. Dr. Nebras, pre-diabetes.
For me, the main message for every patient, for everyone, even for me, is low carb and high intensity exercise or resistance exercise. Not only walking, not only treadmill. So you have to improve your muscles. Muscles will improve insulin sensitivity.
Okay.
Diet will improve insulin resistance.
Excellent.
And it's go both way.
Yeah. Dr. Abir, final comment to your colleagues who are residents.
I'm just having a question for Dr. Nabras, what if the patient already with normal BMI and he is pre-diabetes?
We treat.
Should we still focusing on lifestyle
Yes.
modification and increase the physical activity, or we should start metformin?
Yes, definitely. So no BMI, it will be, I mean, exercise, not weight loss. So exercise itself or increasing muscle mass. There was a debate between should we increase muscle mass or lose fat, which is if you choose one, which you would choose. So choose increase muscle mass. So if you are thin, increase muscle mass, you will improve your diabetes. So of course no weight loss here. Exercise, lifestyle. The metformin come as individualized, as you mentioned. It's individualized. Patient is higher risk. There's no more or no kind of room to improve in lifestyle. So the medication is the key here. It's helpful, yeah. And nowadays there is HOMA-IR, HOMA-IR2, and it was developed as a research, and now it's become as a
Trend.
yes, doing in the center. So there's no data about it, but this is that it gives you this patient has increased insulin resistance or at risk of insulin resistance. So I don't use it, but sometimes patient, if they do it, you can monitor the progress. So he do exercise. If he do HOMA-IR exercise, then you see this improving.
So, Dr. Abir, on your behalf, I would like to say the statement that you were supposed to say to all your colleagues of residents. Please prepare yourself and come on the stage here and deliver a presentation like what you have done today. So, ladies and gentlemen, I would like to thank you all.
Just have one question.
One question. تفضلي. طيب.
To Dr. Nabras, how do you approach pre-diabetic in elderly? Let's say 75-year-old woman with the hemoglobin A1C 6.3, 6.4. What's your best approach for this lady?
So in the study, the DEB study, they found the most significant reduction in incidence of diabetes is in elderly. It was 71%. I mean, the average was 58%. For elderly, it's 70%. So they benefit from lifestyle and benefit from metformin. So in this group, I think it's easier. So it depends on their either active, not active. I think it goes. The treatment is standardized for everyone. Lifestyle benefit were proven very beneficial for every stage of age, every age. So a lifestyle go and the metformin. Anything above 6, we have to add some pharmacotherapy. Even if he is polymedicine or no. I try to avoid medication for people with polypharmacy, but above 6, we have to prevent the complication.
Okay, finally, I would like on your behalf to thank our distinguished speakers for their wonderful contributions and very insightful information that we have learned from them today. Thank you for all of you for attending, and thank you for Merck and for the Saudi Society for Family and Community Medicine. Thanks for Fexus for organizing this event. Looking forward, inshallah, to see you again in the 48th session of the IMC Family Medicine Club. Thank you very much. Have a wonderful night. So we'll be having the dinner downstairs, I believe. And alhamdulillah, we finish right on time.